Good afternoon, my dear students. I am Dr. Athar Fatima, Professor of Pathology. I'll be teaching you the pathology of liver. The main objectives of my lectures will be to teach you anatomy of liver, the bilirubin metabolism, jaundice in detail, general features of liver disease, and liver function tests, hepatitis, alcoholic liver disease, cirrhosis of liver, neoplastic disorders of liver, and hepatic failure. Coming to the anatomy of liver, liver is one of the larger organs of the body. It weighs around 1400 to 1600 grams and constitutes about 2.5% of the body weight. Liver is one of the organs having dual blood supply. The portal vein supplies around 60 to 70% of the blood to the liver. The portal vein collects the nutrient-rich blood from the splanchnic circulation and supplies to the liver. The hepatic artery supplies oxygenated blood from the heart, and it constitutes around 30 to 40% of the blood supply to the liver. Coming to microarchitecture of the liver is described microscopically. Liver is described according to lobular model as a hexagonal hepatic lobule. The liver lobule is 1 to 2 millimeters in diameter around the central vein. Central vein is a terminal branch of terminal hepatic vein with portal tracts at the periphery of the lobule. The functional unit of liver is an acinus, which is triangular in shape with the central vein at the apex and the portal tracts at the base of the acinus. The hepatocytes are arranged in sheets and extending between the portal tracts, extending from the hepatic vein to the portal tract. And these hepatocytes are again divided into three zones: zone 1, 2, and 3. Zone 1 is a periportal, nearer to the portal tract, and the, zone 3 is centriacinar, near the central vein. Different hepatocytic zones are prone to different types of injuries. Like for example, zone 1 hepatocytes are more prone to injury in viral hepatitis. Zone 3 hepatocytes are more prone to diseases like chronic venous congestion in congestive cardiac failure, alcoholic liver disease, injury due to acetaminophen, and injuries due to ischemia. Zone 2 hepatocytes are specifically affected by certain diseases like yellow fever. This is the architecture of liver under the microscope. You are seeing a portal tract with hepatic artery, bile duct, and portal vein. The central vein, a branch of hepatic vein, and cords of hepatocytes extending from the portal tract to the central vein. The cords of hepatocytes are separated from the other cords by dilated sinusoids. The sinusoids are filled with blood derived from portal vein and the hepatic artery. This is the diagrammatic representation of the liver architecture. The cords of hepatocytes are present. There is a bile canaliculi in between the abutting hepatocytes formed due to invagination of the cell membrane of the hepatocytes. The bile canaliculi drain the bile from the hepatocytes is secreted in the bile canaliculi. From the bile canaliculi, the bile will be drained into the canal of Herring's, and from canal of Herring's it will be drained into the hepatic duct in the portal tract. The hepatocytes are separated from the sinusoidal endothelial cells by the narrow space called space of Deci. There are quiescent or stellate cells in the space of Deci, which are storage cells for steroids, and it stores the vitamin A. The sinusoids are lined with the fenestrated endothelial cells, and the Kupffer cells, the mononuclear phagocytic cells of the liver, are present on the sinusoidal surface of the endothelial cells. The space of Deci also has fine, delicate collagen fibers of type 4 collagen. The canal of herring will have oval cells, the stem cells of the liver, which helps in regeneration of the liver parenchyma when there is damage to the liver. Coming to laboratory evaluation of the liver, the liver diseases. The laboratory evaluation of the liver can be done by investigating the integrity of the hepatocyte, by investigating the excretory function of the liver, and by investigating the hepatic synthetic function of the liver cells. These are serum tests and they are called as liver function tests. The hepatocyte integrity can be assessed by assessing the serum enzyme levels, the levels of SGOT, SGPT, and LDH in the serum. Whenever there is hepatocyte disruption, the hepatic enzymes, the hepatocellular enzymes will be released into the circulation and their concentration in the serum will be increased. The excretory function of the liver can be assessed by assessing the commonly excreted substance in the bile, like for example bilirubin, which is commonly excreted by the liver into the bile. So by measuring the serum bilirubin concentration in the blood, we can assess the excretory function of the liver. The serum bilirubin, we usually generally measure total serum bilirubin concentration, where you measure the unconjugated plus conjugated bilirubin concentration in the blood, and you also measure the direct or conjugated bilirubin in the blood. This helps in differentiating jaundice, whether it is conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia. You can also measure the concentration of bilirubin in the urine, and you can assess the levels of bile salts in the blood. The serum alkaline phosphatase enzyme, which is present in the bile canaliculi, will be present in higher concentration whenever there is damage to the bile canalicular cells. Hepatocyte synthetic function can be assessed by measuring the substances which are synthesized by the hepatocytes. The protein and coagulation factors are synthesized by the liver, so you can measure serum albumin levels and also investigate the coagulation profile of a patient. And the most commonly used coagulation tests for assessing the liver function are prothrombin time and partial thromboplastin time. Hepatocyte metabolic activity can be assessed by measuring the serum ammonia levels. The ancillary investigations which are used for investigation of liver disorders are the radiological investigations, which includes the ultrasound abdomen, the CT scan of the abdomen, and MRI of the abdomen. The radiological investigations help in assessing the size of the liver. You can assess the liver architecture, whether the architecture of the liver is maintained or altered, like in cirrhosis of the liver. You can also look for any space occupying lesion in the liver. FNAC. The role of FNAC in the diagnosis of liver disorders is whenever there is a space occupying lesion in the liver, the FNAC helps in differentiating whether the space occupying lesion in the liver is a benign lesion or a malignant lesion. It also helps in differentiating a malignant lesion, whether it is a primary hepatocellular carcinoma or a secondary deposits in the liver. The role of biopsy in the diagnosis of liver is mostly to predict the outcome of the disease, where it is mostly used to stage and the stage the disease process. Grading, it is basically used for grading and staging of the disease process, but definitely it can be used for the diagnostic purpose whenever there is abnormal liver function test without a known cause for abnormality. A liver biopsy will definitely help in making a diagnosis of liver disorder. ERCP, endoscopic retrograde cholangiopancreatography, is used to assess the patency of the biliary tract. Angiography, to study the vascular pattern in the liver disorders, which will be abnormal in cirrhosis of liver, or some SOLs with abnormal vascular pattern can help in differential diagnosis. The other ancillary investigations which are used are tumor markers. The most commonly used tumor markers for the differential diagnosis of liver disease is alpha fetoprotein and carcinoembryonic antigen, which is used for differentiating a malignant SOL, space occupying lesion in the liver, whether it is a primary hepatocellular carcinoma or a metastatic tumor from the stomach or pancreas. Alpha fetoprotein is markedly raised in hepatocellular carcinoma, and carcinoembryonic antigen will be raised in adenocarcinomas from the gut and pancreas. Immunological investigations can be used in the diagnosis of liver disorders, like autoantibodies different types of autoantibodies can be measured in whenever you are suspecting autoimmune hepatitis. Viral antibodies can also be used for diagnosis and for staging of viral hepatitis. The general features of liver diseases: primary disease. The liver disease can be a primary disease of the liver, like viral hepatitis, or the liver disease could be a secondary to a systemic disease like heart failure or disseminated cancer. Mechanism of injury and repair. Depending on the type of injury, the duration of injury, the severity of injurious agent, the injury to the liver cells, the hepatocytes, could be a reversible injury or an irreversible injury. Reversible injury can be seen as ballooning degeneration, steatosis, and cholestasis. The example of reversible injury is taking alcohol for a short period of time, where you see steatosis, which will revert back to normal once the injurious stimuli is removed. Once you stop taking alcohol, the steatosis, which is a reversible injury, will revert back to normal. Irreversible injury, when there is the injurious stimuli is present for a longer time, persistently present, or when it is very severe, it causes cell death. Cell death can occur because of necrosis, or it could be due to apoptosis. Necrosis of the hepatocytes can be in the form of single cell necrosis, dropout necrosis, or focal necrosis. For example, as seen in acute viral hepatitis, where you see intralobular hepatic necrosis, where single cell will be necrosed surrounded by inflammatory cells, and later on it will be regenerated. Confluent necrosis, where there will be zonal necrosis of the hepatocytes. For example, in yellow fever, zone 2 hepatocytes will be necrosed. Or whenever there is hypotension or shock, the centriacinar hepatocytes are more prone to develop a hepatic necrosis. Bridging necrosis extending from the central vein to the portal tract, or extending from portal tract to portal tract. It is more commonly seen in chronic diseases of the liver, like chronic hepatitis B, or chronic hepatitis C virus infections. Submassive or massive hepatic necrosis, where there is where the entire liver or major part of the hepatocytes are necrosed. The example of this is fulminant hepatitis causing hepatic failure. Apoptosis. In apoptosis, the hepatocytes are shrunken with dense eosinophilic cytoplasm and karyorrhexis of the nucleus. They are seen as eosinophilic bodies and they are also called as Councilman bodies. After injury to the liver, the repair of the injured liver occurs due to scar formation and regeneration. Because the hepatocytes are like stem cells and they have a lot of regenerating capacity, if there is only parenchymal damage with intact the supporting tissue, then regeneration of the hepatocytes can occur. Whenever there is damage to the supporting structures, then the healing occurs by scar formation. Coming to the mechanism of liver damage or fibrosis. Whenever there is injurious stimuli, the injurious stimuli can damage the hepatocytes directly. It can cause apoptosis of the hepatocytes, it can cause hepatic dysfunction and necrosis of the hepatocytes, or sometimes it can just cause hepatic dysfunction without necrosis. For example, in acetaminophen toxicity, there is just diffuse hepatocyte dysfunction without any obvious necrosis. The necrosis can also be because of the cytokines which are produced by the mononuclear phagocytic Kupffer cells. The dying hepatocytes, the cytokines and the chemical mediators produced by the dying hepatocytes, the Kupffer cells and activated endothelial cells will cause activation of the stellate cells. These activated stellate cells will be converted to myofibroblastic cells, which are stimulated to proliferate, and also they start producing increased amount of collagen, especially type 1 and type 3 collagen, which gets deposited in the space of disc. So whenever there is fibrosis, the earliest fibrotic changes will start in space of disc, especially around the central vein, from where it may extend to other areas. Then coming to jaundice. Jaundice is one of the very important topic, and not just for the examination point of view, but in view of your practice after your graduation. First, we will learn certain terminologies which are interrelated and sometimes used interchangeably. Hyperbilirubinemia. What is hyperbilirubinemia? Hyperbilirubinemia is increased concentration of bilirubin in the blood. The normal bilirubin concentration is 0.2 to 1.2 milligrams per deciliter. Then what is jaundice? Jaundice is a sign due to hyperbilirubinemia. When the concentration of bilirubin is above 2 milligrams per deciliter in the blood, there will be yellowish discoloration of the skin, mucous membrane and sclera, which is called as jaundice. Icterus is a very specific term. It is used to describe the yellowish discoloration of the sclera. The bilirubin has high affinity for the elastic tissue, and sclera is rich in elastic tissue. So earliest changes of hyperbilirubinemia can be seen in the sclera. Cholestasis. Cholestasis is a condition where bile cannot flow from the liver to the duodenum. Thereby, the bile is retained in the hepatocytes and which later regurgitates into the blood. So in cholestasis, there will be regurgitation of bile into the blood, thereby increasing the concentration of serum bilirubin, increasing the concentration of serum bile salts, and also cholesterol in the blood. So the proper definition of jaundice is yellowish discoloration of the skin, mucous membranes, sclera and body fluids due to excess serum bilirubin above 2 milligram per deciliter. Then coming to the origin and metabolism of bilirubin. 85% of the heme is derived from the senescent RBCs. Senescent RBCs, once the RBCs live for 120 days, their normal lifespan, they are removed from the circulation by the mononuclear phagocytic cells, predominantly in the spleen. And around 10% of the heme is derived from ineffective erythropoiesis, which is occurring in the bone marrow. In ineffective erythropoiesis, the immature erythroid precursors will be destroyed in the bone marrow by the mononuclear phagocytic cells in the marrow, and the heme so formed will enter into the mononuclear phagocytic cells, where it will be metabolized. About 5% of the heme is derived from the heme proteins. These are heme containing cellular enzymes like cytochrome P450. The heme so formed will be metabolized. The iron will be separated and will be used for restoring the serum. Body iron stores will add up to the body iron stores, and the protoporphyrin so formed will be metabolized by heme oxygenase to form biliverdin. The biliverdin will be converted to bilirubin by biliverdin reductase enzyme. The bilirubin, which is formed by the mononuclear cells, will be released into the circulation. The bilirubin will bind with the albumin and will be taken up by the hepatocytes. The bilirubin in the blood bound to the albumin is not water soluble. It is fat soluble, not water soluble. So whenever there is increased concentration of bilirubin in the blood, it cannot be filtered by the glomeruli and it is not excreted in the urine. The bilirubin, which is taken up by the hepatocytes, will be conjugated by uridine diphosphate glucuronyl transferase UGT enzyme. The conjugated bilirubin then will be secreted into the biliary canaliculi, and from the biliary canaliculi they go to canals of Herring, and from there it will be transported through to the hepatic ducts in the portal tract, and from there it will be carried and stored in the bile in the gallbladder. And whenever it is required from the gallbladder, the bile will be secreted in the duodenum, and it helps in the digestion of food, especially the fatty food. Once the bile enters the gut, it will be metabolized by the bacterial deconjugases and it will be converted to urobilinogen. Major part of the urobilinogen is excreted along with the stools as stercobilin, and which is responsible for the color of the stools. A part of urobilinogen will be absorbed into the circulation, and that will be filtered by the glomeruli, because the urobilinogen is water soluble and can be filtered by the glomeruli and excreted in the urine, and this is responsible for the normal color of the urine. So, diagrammatic presentation of the bilirubin metabolism. The senescent heme derived from the senescent red blood cells. will be converted by the macrophages to bilirubin. The bilirubin formed by the macrophages will be released into circulation, where it will bind with the albumin and later on taken up by the hepatocytes. In the hepatocytes, it will be conjugated, and the conjugated bilirubin, which is made water soluble, the bilirubin which is fat soluble, not water soluble, will be converted to water soluble conjugated bilirubin and secreted into the biliary canaliculi. From there, it will be taken up and stored in the gallbladder. From the gallbladder, whenever it is required, it will be secreted into the duodenum at the ampulla of Vater. In the gut, it will be converted to urobilinogen and it will be excreted in the stools and partly reabsorbed and undergoes enterohepatic circulation, which is later on filtered by the glomeruli and excreted in the urine. So the problem can be at so many levels. It can be due to increased production. The jaundice could be because of problem at multiple levels. The problem could be at the level of increased production, or it could be because of defective uptake, or the problem could be because of defective conjugation, or the problem could be due to defect in the secretion into the biliary canaliculi, or it could be obstruction to the bile flow. Then coming to the classification of jaundice. The jaundice is classified by different methods. Here I am presenting few of the ways of classifying jaundice. Classification of jaundice based on the type of hyperbilirubinemia. It could be predominantly conjugated hyperbilirubinemia or predominantly unconjugated hyperbilirubinemia. Classification of jaundice based on pathological mechanism. It could be hemolytic jaundice or prehepatic jaundice, hepatocellular jaundice or the hepatic jaundice, obstructive jaundice or posthepatic jaundice. The other way of classifying jaundice is based on the management of jaundice. It is classified as the medical jaundice or the surgical jaundice. In the medical jaundice, the example is viral hepatitis, where the treatment is predominantly medical. The example for surgical jaundice is carcinoma head of the pancreas causing obstruction to the bile flow. The treatment is nothing but only surgery. So jaundice is a sign and a symptom, not necessarily of a liver disease. It could be because of hemolytic anemias also, or it could be because of obstruction to the bile flow. Causes and classification of jaundice. Predominantly unconjugated hyperbilirubinemia can be seen due to increased production of bilirubin, reduced hepatic uptake of bilirubin, or because of impaired bilirubin conjugation. Increased production of bilirubin could be because of hemolytic anemias, could be because of ineffective erythropoiesis, or could be because of resolution of large hematoma. The jaundice will be very transient during in resolution of large hematoma. Once the hematoma is resolved, the jaundice will subside on its own. In hemolytic anemias, there is increased destruction of red blood cells in the mononuclear phagocytic cells, causing increased production of bilirubin. In ineffective erythropoiesis, for example in thalassemias and certain pernicious anemias, there will be increased destruction of the premature erythroid precursors in the bone marrow and resulting in increased production of bilirubin. Reduced hepatic uptake of bilirubin is seen in certain diffuse liver diseases like hepatitis, or due to certain drugs that interfere with the membrane carrier system, and sometimes also seen in Gilbert syndrome. Gilbert syndrome is because of defect in the impaired conjugation, but sometimes there is defect in the uptake of the bilirubin. The impaired bilirubin conjugation could be because of, as seen in physiological jaundice of newborn. In physiological jaundice of newborn, the liver is transiently immature, and the conjugation of the bilirubin is low because of low activity of uridine glucuronide transferase enzyme, and there is increased production of bilirubin due to increased hemolysis of the red blood cells in the newborn child. In Gilbert syndrome, there is deficiency of the enzyme uridine glucuronide transferase, and in Crigler-Najjar syndrome Crigler-Najjar syndrome is also there is a defect in the uridine glucuronide transferase enzyme. In type 1, there is complete absence of the enzyme activity. In type 2, there is decreased activity. The enzyme is present and the activity is present, but the activity is low. Then classification of jaundice, continuation. Predominantly conjugated hyperbilirubinemia is seen in conditions where there is decreased hepatocellular excretion of the conjugated bilirubin, or due to impaired intra and extrahepatic bile flow. Decreased hepatocellular excretion of the conjugated bilirubin into the biliary canaliculi due to deficiency of bilirubin canalicular transport protein is seen in Dubin-Johnson syndrome and in Rotar syndrome. Dubin-Johnson syndrome is autosomal recessive disorder. It is not clinically significant, but grossly the liver is pitch dark, very dark green or blackish green in color. Rotar syndrome is also due to defect in secretion of the conjugated bilirubin into the bile canaliculi, but grossly and microscopically the liver is normal. In Rotar syndrome, apart from the secretion of the bile into the biliary canaliculi, there are defects in cellular uptake of bilirubin and also in conjugation of the bilirubin. Decreased hepatocellular excretion could also be because of diffuse liver damage like in hepatitis. Impaired intra and extrahepatic bile flow could be because of inflammatory destruction of the bile ducts as seen in primary biliary cirrhosis. It could be because of obstruction of the biliary tract by gallstones, or obstruction to the bile flow by carcinoma head of the pancreas, or sometimes obstruction can occur due to parasites like hepatic liver flukes. Coming to the discussion of different causes of increased hemolysis, extravascular hemolysis or ineffective erythropoiesis, there is increased destruction of RBCs in the reticuloendothelial cells, which occurs predominantly in the spleen. In ineffective erythropoiesis, there is destruction of immature erythroid cells in the reticuloendothelial cells of the bone marrow. In these two conditions, the conjugating capacity of the liver is normal, but the production of bilirubin is overwhelming the conjugating capacity of the liver. Therefore, there is increased unconjugated bilirubin in the blood, and there is increased production of urobilinogen in the urine. The bile salts and the cholesterol levels in the blood are normal. And these people are at increased risk of developing gallstones because increased quantity of bilirubin is being excreted into the bile. Therefore, patients with hemolytic anemias present with jaundice and gallstones. Example, hereditary spherocytosis. Sometimes the patient presents only with the gallstone with episodes of jaundice. So whenever there is an young patient presenting with the gallstones, always he or she should be evaluated for hemolytic anemia. The physiological jaundice of newborn. Newborn liver is transiently immature and has low uridine glucuronide transferase activity. Because of this, the second thing is there is increased production of bilirubin due to hemolysis, increased excess of hemolysis after birth. Due to these two factors, immature liver with excess of heme production causes decreased conjugation of bilirubin and thereby increasing the unconjugated bilirubin concentration in the blood. Unconjugated bilirubin is not water soluble, it is fat soluble. Therefore, the unconjugated bilirubin concentration, if the unconjugated bilirubin concentration are very high in the newborn, it gets deposited in the basal ganglia. Because the blood-brain barrier is also not well developed in the newborn child, leading to neurological deficits and death. The Gilbert syndrome, it is in Gilbert syndrome there is mild decrease in the activity of uridine glucuronide transferase activity. It is an autosomal recessive disorder. In this condition also there is increased concentration of unconjugated bilirubin concentration. Jaundice is not normally present, but whenever there is stressful conditions like severe infection, the patient will have jaundice. This condition is clinically not significant. Then coming to Crigler-Najjar syndrome. Crigler-Najjar syndrome, there are two variants, Crigler-Najjar syndrome type 1 and type 2. In type 1 Crigler-Najjar syndrome, there is a complete absence of uridine glucuronide transferase activity, and there will be increase in concentration of unconjugated bilirubin. It is very fatal, and the child usually dies within 1.5 years after birth. In type 2 Crigler-Najjar syndrome, the activity of uridine glucuronide transferase activity is slightly decreased, but it is viable. The child can survive. Dubin-Johnson syndrome, there is deficiency of the bilirubin canalicular transport protein in this condition. It is an autosomal recessive disorder. Grossly, the liver is very dark in color. It is not clinically significant. It doesn't cause any symptoms, but on gross examination of the liver is very darkly stained, darkly pigmented, and the hepatocytes under microscope shows pigmented granules in the cytoplasm. The Rotar syndrome is also due to deficiency of bilirubin canalicular transport proteins, and it is also an autosomal recessive disorder, but in Rotar syndrome, the liver is grossly and microscopically normal. So it is considered that in Rotar syndrome, apart from the defect in the biliary canalicular transport protein defect, there are other associated defects where the uptake of bilirubin by the hepatocytes and conjugation of bilirubin by the hepatocytes is also defective along with canalicular transport protein defect. Next, coming to the biliary tract obstruction. Jaundice caused due to biliary tract obstruction. The obstruction to the bile flow could be because of gallstones. It could be because of pancreatic carcinoma causing obstruction at the ampulla of Vater. It could be because of cholangiocarcinoma, or sometimes because of parasites like liver flukes which cause obstruction to the biliary tract. Whenever there is obstruction to the bile flow, there is the bilirubin formation, uptake, and conjugation and secretion is normal. Therefore, in this condition, the conjugated bilirubin concentration is high in the blood. Conjugated bilirubin is water soluble and can be filtered by the glomeruli, therefore also excreted in the urine, causing high colored urine. In hemolytic or prehepatic jaundice or jaundice where there is increased concentration of unconjugated bilirubin, the color of the urine is not because of bilirubin in the urine. It is because of urobilinogen, which is produced in excess concentration because of increased bilirubin metabolism, which causes high colored urine. But in obstructive jaundice, where there is increased concentration of conjugated bilirubin, the conjugated bilirubin being water soluble can be excreted in the urine and causes high colored urine. Whenever there is obstruction to the bile flow, the bile is retained in the hepatocytes and this bile will regurgitate into the blood. So, apart from bilirubin, there will be increased concentration of bile salts and cholesterol in the blood. Increased cholesterol in the blood will be deposited in the skin as xanthomas, and increased bile acids in the blood will cause pruritus. Since there is obstruction to the bile flow into the gut, there is defect in the metabolism of the fat, causing steatorrhea with malabsorption of the fat soluble vitamins. Since bile is not excreted into the gut, the color of the stools is mainly because of the stercobilin. The stools are pale. So, in obstructive jaundice, the patient will have icterus, pruritus due to increased bile salts, and pale, bulky stools because of absence of bile in the gut. And there will be decrease or absence of urobilinogen in the urine. So, if urobilinogen is present in the urine, it is never because of obstructive jaundice. In obstructive jaundice, there is no or absent urobilinogen in the urine. Coming to viral hepatitis is inflammatory disruption of hepatocytes and small bile ductules. In this condition, there is increased concentration of both conjugated and unconjugated bilirubin because there are diffuse alteration in the hepatic function. So, there will be partially decreased uptake by the liver, which is responsible for unconjugated bilirubin concentration, and there is partially retention of the bilirubin in the hepatocytes, which is responsible, or defective excretion of bile because of disruption of the bile ducts. There will be retention of whatever conjugated bilirubin is present will be regurgitating into the blood and causing increased concentration of both conjugated bilirubin and unconjugated bilirubin. The dark color of the urine is because of increased urobilin and also because of increased bilirubin in the urine. The dark color of the urine is because of increased bilirubin in the urine, and the urobilinogen concentration will be normal or decreased. Thank you.